and then finally you can do it. So these were the few surgical tips I just wanted to share with all of you. Thank you.
Thank you, Vijay. Now I invite Dr. HARBANSH LAL, our Vice President for the toric oil for irregular cornea.
So I thank Dr. Vijay Nichlani for giving me this opportunity. And dear friends, like as we know that the demand for the toric IOL is rising, and there are a lot of patients who have got a corneal astigmatism or irregular corneal astigmatism, those who need to be corrected upon. So there are many causes of irregular corneal astigmatism, but what we need to know whether the pathology is progressive or non-progressive. Of course, you cannot put a toric IOL in a progressive pathology. If it is a non-progressive, is he a contact lens user or not? Any contact lens user, you cannot use the toric IOL because contact lens covers the astigmatism better than any toric IOL can cover. So I'll be taking radial keratotomy as a prototype. And how radial keratotomy used to work was, we used to give a radial incision with the pressure of the IOP, the paracentral area will go up and central area will flatten. But unfortunate part of this is that this hyperopic shift keeps on happening throughout the life. That's the reason the flattest corneal median is in the centermost area, and we are not able to measure that area. This is where the error comes from. And then these incisions causes irregular astigmatism. So I'll just give you 2-3 case scenarios. This was a 51-year-old male with the RK 15 years back with the refraction of -4, -3.5 at 170 degree. And once on an optical biometer also you will see the astigmatism is same, more or less on the same axis, and the IOL power is coming 13.5. But if you see the pentacam, the cylindrical power is the same, but the keratometric values are a little more. So if you see this, if your target refraction is 0, and when you put on to IOLcalc.crs.org, this is a very good software. It does nothing intelligent. It just gives you all the readings at one pace. If you put all the readings onto the IOL master, also you will get the same reading. So there is nothing extra intelligent, but it will give you all the formulas at one place. Now if you see over here, pentacam is usually more accurate, gives you the flattest reading, but in this case, pentacam is giving 39.5, while the biometer is giving 37.49. That's the reason the biometer is accurate, but pentacam reading is not accurate. And I always target -1. So when we target -1, then you will find that what we need the IOL is a 15 diopter. And this 15 diopter is okay because the patient has got a refraction in minus. Most of the patients of RK are usually when they come to, they using plus glasses. If they are using plus glasses, then this reading is absolutely wrong. Because myopic patient will need little lower than 21 diopter, and hyperopic patient will need little more than 21 diopter. So this is the another prototype of a patient. You will see over here 6.25 diopter astigmatism, and you see the biometry reading is 21. And on the pentacam, and this when we calculate on both of them, IOLcalc.crs, the target refraction 0, we get a pentacam reading, the power was 27.49, and on a biometer it was 21. And once we put on a -1, then it is 29. So now see the gap. From 21 it goes to 29. And if you see the lens star reading was 36.61, which was much more steeper than the pentacam reading, which was 32.5, which was 4 diopter flatter. So in this case, we'll take a pentacam reading, calculate the maximum, whatever formula is, whatever you are getting the maximum IOL power, target -1. So we went on with the 29 diopter of IOL. And so far as the what axis should be used, so the biometer is giving axis of 172, pentacam 145, but irregular, whenever there is a cornea is irregular, refraction is more reliable than pentacam and biometer both. So in this case, refractive error was at 164 degree, we targeted for 164 degree. So all irregular cornea, refraction of the astigmatism is more important than your pentacam or a biometer reading. So we went according to the refractive error. This is the another case scenario, 32 incisions, and you will notice that in this, the IOL power was coming 10.5. When we went and calculated an IOL calc, this was in my initial case when I didn't realize where the mistake was. When targeting minus was coming something 11.52, we went for 12.5, and this post-operative patient had the undilated AR of 13.5 and plus 1.5. Acceptance was plus 9 with plus 4.5. You can see the amount of error. I mean, IOL calc maximum minus 1 targeted, still the error was to this tune. So we went and did the IOL exchange after 1 month, and we put on a 27 IOL, still patient was plus 0.5. So then we tried to analyze why it is not still 0 while we are putting so much pupil lens. So normally optical biometer, when you see the reading over there, one change in the IOL power changes the refraction by 0.66, 0.67. 2/3 of the effect you get. You see any optical biometer reading over here. Like if you see 11 is minus 0.02, we put on a 12, patient will become minus 0.68. So nearly 2/3 ratio is there if you see the optical biometer. So in this case, it would have taken that into the consideration. Then 9 plus 4.5, 11.25 is the spherical equivalent, 1.5 times 17. Add this 17 into the 12.5, which we already used. Probably patient needed 29.5, not 27. So probably if we had used around 29, 29.5, patient would have been better off. In the case 4, the IOL power between when we calculated was coming plus 2 and minus 6. So this was absolutely haywire, it is not possible. So we did the absolutely simple cataract section and went, and the patient had post-op restriction of plus 13. We went and implanted 26 diopter of IOL. So the what I will like to emphasize that the take flattest keratometric value available on any of the equipment, calculate an IOL calc ASCS.R, target refraction between minus 0.5 to minus 2 depending upon the distortion of the cornea. Any keratometric value above 40, that means you are measuring the actatic area, you are not measuring the flattest area. The error where we had, there the steepest, there was one axis was at 46 diopter. So we didn't take into that account. Any biometric IOL power, if you are using less than 18 biometric value is coming, if the patient is not myopic, if patient is hyperopic, probably you are wrong. So, and most of these patients need IOL power around 24, 28. So if the IOL power is coming less than that, you have got to be very, very careful. Thank you very much for your kind attention.
Thank you,
for giving me the
Dr. HARBANSH LAL. Now